Today we are going to have the Organ Donation Committee meeting, the 6th CME of 6. Today's topic will be on the heart and lung donation. Every month we are having with the different donations, and now I request our Organ Donation Committee member, Dr. G. N. Suguna, to give the IMA prayer and physician's prayer.
Good evening, all. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you.
Thank you, Dr. Suguna. Now, the welcome address by me, the chairman of the Organ Donation Committee. I welcome our state IMA president, Dr. K. M. Abul Hassan sir, for in spite of his busy schedule, able to join the CME programs regularly. And I also welcome Dr. P. Gunasegaran, the Vice President of the National Headquarters, and Dr. D. Sendamil Pari sir, Dr. P. Sengutuvan sir, Dr. B. Sridhar sir, the State President-elect 2025, and our State Secretary, Dr. Karthik Prabhu sir, Dr. Gauri Shankar sir. At the outset, I like to thank Professor Dr. P.R. Murugesan from PSG IMS Hospital, Cardiothoracic professor, for nicely organizing this heart and lung donation program for this month. And I also welcome Dr. C. Ananthanarayabnan, who is going to give a talk, and also Dr. P. Sivakumar and Dr. G. Pradeep for joining today's program. See, actually, what we are doing is we are conducting each and every month a different set of a program we are having. This is today's program, what I have already told. And the organ donation awareness meet. To conduct, with the main aim of our organ donation committee is to conduct organ donation awareness meeting in all the medical colleges, nursing colleges, all engineering colleges, Rotary clubs, Lions Club, and like forums in the IMA regional branch areas. And we have already issued the English handouts on organ donation and also Tamil handout. To increase the awareness, if a person is brain dead and donates the organ, the branch IMA office bearers to meet the relative during the funeral or after in their home and thank them by giving a citation, so that the people will be more obliged to give the brain organs. Then only they will know more about it. And regarding the IMA meetings, all the branches are conducting the IMA meetings. Minimum 5 minutes to be allotted to talk about the organ donation in each meeting in the form of show the PowerPoint about the organ donation. If there is any organ transplant specialist in the branch, I request them to talk about their experiences during the month. And if not available, we can invite from the nearby branches to give the talk. Show the waiting list for organs necessity to obtain list from the Transtan and show it to all your meetings. To observe 1 minute silence for the brain death donor who have donated in that region. The organ donation workshop. We like to conduct a regional organ donation awareness workshop to college students, paramedical staff, doctors, so that all the procedures can be explained in detail and educate more people. The hospital coordination meet. To conduct a regional donor hospital coordination meet by inviting donor recipient transplant hospital doctors and conduct meeting once in a month with the organ donation committee members of the IMA TNSB. The Transtan is to spread the messages about transplant. Transplant Authority of Tamil Nadu request all the IMA members to visit at least one time to that website to know more. And we also created a Google form for organ donation. If you click in this form, immediately you can register for the organ donors. And we are going to create another Google form for the general public. To increase awareness about the organ donation, we have created awards for the good performing branches with maximum donor registration in our website, and the branch conducting maximum donor awareness meetings to be given during the state conference in the December. And the activity in this month was by the Erode IMA branch conducted workshop on organ donation. And in that, our national president, Dr. R.V. Asokan, attended the program. And the founder director of NOTO, Dr. Vasanthi Ramesh, attended the program, and she gave a nice lecture. And Dr. Mohan Prasad, Dr. Gopalakrishnan, and Dr. Mitra Prasad were given. And the special address was given by our president. And the program was attended by Lena Tamilvanan also. And it was well attended by the around 250 people. And this was the meeting which were conducted on that day. And in that meeting, one of the persons from the Erode by name Bhupati E, who has donated the organs, and the organ donation donor family was felicitated by the IMA branch people at the time. This was the scene, and like that, we do it, people will be more interested in donating the organs. And the organ donation activity in Coimbatore Medical College Hospital, Coimbatore, Virudhunagar person Suresh Kumar, who had died, and the brain death was certified, and he has given life to 5 people, and the heart and liver and all the things were donated. And at the end, the Coimbatore Medical College Dean Dr. Nirmala and the donor body handed over for the families with the due respect. This is what we should do, and so then this today's program. So I welcome you all for this the organ donation committee 6th CME. Every month we will be having. The next month we will be having about the liver transplantation, because the hepatitis day is coming in the next month. Thank you one and all. Now I invite our President Dr. K. Mabulasan sir to give the presidential address and inaugurate the meeting.
Thank you, Dr. Rajesh. I am very happy and amazed to see the committees working very dedicatedly. The committee is an asset to IMA Tamil Nadu State Branch, if I am not exaggerating. Congratulations to the entire team. And today we are having our 6th meeting and going to discuss about the transfer or donation of lung and heart, which are gaining so much importance of late, that many patients live longer times because they get a new heart and new lungs. These particular areas is gaining very importance regarding the heart and lung transplantation. About 2 decades ago, it was thought that it was not feasible. So there is an evolution of modern medicine today, and they will be seeing a more number of developments is going to happen in transplantation medicine. I expect that at the end of the day, there will be more doctors pledging their organs and stand example for cause of the cadaveric donation has to be improved in our state. And today we have the Young Doctors Day in the morning in College of Chennai, and returning where I was speaking to the young doctors that they should be the champions of organ donation. And the event, all success, and happy to inaugurate this seminar. Thank you very much. Over to you, Dr. Rajesh.
Thank you, President sir. Now I invite our Dr. S. Karthik Prabhu sir, the Honorary Secretary of IMA TNSB.
Thank you, sir. Most respected President and all the leaders. Good evening, everybody. Wonderful meeting, sir. Or a series of meetings. Today is heart lung. Nalla topic, sir. Though an expensive procedure, we don't get enough organs for many people to get benefited. So this program, I'm sure, will be an eye-opener for many to motivate many people. So all the best, sir. Best wishes.
Now straight away we will go for this today's program. And now I invite Professor Dr. P.R. Murugesan, sir, to take over the session and coordinate with the and moderate the meetings and start with his initial topic, first topic on current practice and future perspectives of heart and lung transplantation in India. Over to you, Murugesan, sir.
Thank you, sir. Thank you very much. I am very glad and pleased to be here with my team to highlight the current practice of heart-lung transplantation in our nation. Heart-lung transplantation compared to 2 decades.
Sir, you slideshow potter.
Yeah, sure. It's well appreciable and standardized for the care of end-stage heart and lung disease, where we have a good short-term outcome, and this need a lot of teamwork. So teamwork in the sense we have one end is the donor, another one is the recipient, where we need to prepare the recipient till the time where you get an appropriate deceased donor for the organ. In compared to other solid organ transplantation, where we deal with renal and liver in the current scenario, the solid organ transplantation, the renal, liver, the next is the heart, and the fourth is in the lung. So we are giving a sustainable result over these 2 decades with renal, liver, and the recent updated is the heart and lung. So our program is started 2 years back. Now we are stabilized the organ procurement as well as the transportation and transplantation. The 3 corner issue in this, the donor assessment and procuring the organ from the donor place, then transportation to the center at the maximum of minimizing the cold ischemic time. Probably once you reach the institution, then your implantation is going to be very clear cut, and we may not waste more time to implant the organ to reperfuse. So here the current scenario, whatever is happening, if it's in and around the Coimbatore district, our the transport time and the minimizing the cold ischemic time will be a very short. It's less than 3 hours. So that gives a very good graft survival in a immediate post-operative follow-up as well as the long-term outcome. So in this, I want to highlight that whatever is happening in and around Tamil Nadu transplantation program, solid organ, the first thing is determining the result is the reachability of the donor organ to the recipient center. The second one, the technicality of the harvest as well as the transplantation. The third one is the immediate post-operative care and the long-term follow-up with various stipulated biopsies and other immunosuppressant therapy. In this, in our institution, we have standardized the practice of heart and lung procurement as well as transportation and transplantation. So with this, before opening my talk, I'd like to introduce my colleagues. First, Dr. C. Ananthanarayabnan, who is a senior consultant cardiac surgeon, associate professor in our department. And his special area of interest is minimal access surgery, including robotic cardiac surgery, complex pediatric congenital cardiac defect correction, and aneurysmal procedure for the aorta, and heart-lung transplant program. And he is keen in sustaining patients with end-stage advanced heart failure with mechanical circulatory support, including the ECMO and other facilities which are available for sustaining the recipient to receive the heart. And he will be talking about the advanced heart failure, when to refer to a center for transplantation, and as well the end-stage heart management with the mechanical circulatory support. My second speaker is Dr. Sivakumar. He is our critical care anesthesiologist, critical care cardiac unit head. And he's taking care of all the donor assessment as well as the perioperative management of the recipient. And he will be talking about the optimizing the donor status for organ harvest. And the third speaker will be our Dr. Pradeep and he's our lead in heart lung transplant program. He's have a vast experience with working with Dr. K.R. Balakrishnan. He's a professor and lead in the organ transplant program. And we have a collaborative operation in this thing, conducting a study on organ transport system. So that's going to really change the scenario in the future. I want to talk about the current perspective and the future, what we do in organ transplantation to minimize this warm as well as cold ischemic time. That's the two things is going to decide about the organ healthy status before it reach the recipient body. In that, recently we are conducting a study on animal lab to establish a machine as an organ transport system to improve this kind of transport issue even over 6 hours from one place to the recipient site. Now we have a problem with even airlifting. If any delay over 4 hours, the organ, the status to the recipient is not going to be a great because of the other insult by the ischemic changes in the heart as well as the lung. So ideally, the heart or the lung should be done within 3 hours of time for a better organ survival and reperfusion and immediate graft function and the acceptance by the recipient body. So in that, probably Dr. Pradeep is having a good hand-on experience with heart lung transplant program. He was attached with Dr. KRB for long, and he will be talking about the immediate outcome and long-term follow-up. That's the area where we need to concentrate more for a better long-term outcome. So we have 4 speakers, including me, and Dr. Ananthanarayabnan will talk about when to refer a case in advanced heart failure for heart transplantation and further support. And Dr. Pradeep will talk about the immediate and long-term follow-up management. And Dr. Sivakumar will talk about the donor assessment and maintaining a donor for a better organ perfusion and explantation. With this, I will move on to the rest of my team. Dr. Ganeshan is a professor of cardiac anesthesiologist, and Dr. Sai sir is our another supportive cardiac anesthesiologist for our organ transplant program. Rest of my team, including our perfusionist and the anesthesia technologist, all is here to witness the presentation. I'll go ahead with my presentation. The whole presentation, in fact, is dedicated to this particular person, Miss Sanju Vigasini. Sanju Vigasini is a recent past is happened event. The thing is, he was known to our colleague, Dr. Sivakumar. We used to conduct organ awareness, donation awareness program at least once in few months. Recently, we had at GRG College for Women, and before that, we had at PSG ITEC. And all this area where we try to educate the young crowd not to donate the organ to protect themselves from a major road traffic accident and brain injury. Incidentally, this Sanju Yasini was one of the attending student on that kind of awareness program in Erode, and that Sivakumar was recalling. So he was there for that awareness program, and this girl had a spontaneous bleed, extensive intracranial bleed, and they could not salvage the issue. Then he was kind of consent for donating organ after the initial awareness program. We are really shocked. We should really thankful for the family where she was donated organ for all these different part of our state, and people surveying with her organ in different need, heart, lung, and both kidneys. All these things is donated for her. And the whole program is dedicated for Sanjeev Sahasini because he is detrimentally given the consent before our unfortunate event. The thing is, the positive thing is he didn't have a road traffic accident. That's why we want to promote one side the organ donation concept of our need, and another area where we want to completely off the major catastrophic road traffic accident to a 0 level, because one area where there is a donation, where there's a brain death, it should not be a secondary to a major road traffic accident. That's our willingness in all the way whenever we go and talk about the organ donation awareness. So no road traffic accident, a spontaneous bleed or something happening which is not recoverable for the brain, that's the best donor for us throughout our professional career to keep this in a very peaceful and acceptable way. So that's the way this girl is given her all the organ, whichever is solid and it's for donation in the recent past, and the recipient all is doing well. That's the recently we had a kind of message that everybody is doing well. So with this, I'll move on to the first few minutes on heart explantation and implantation. Just for a general idea, if the renal transplant is a quite standardized and we take the kidney from the living donor or deceased donor or closely related living donor and implant to the pelvic area where the external iliac artery and the vein used for is a simple single vessel on the artery and the vein anastomosis. The process is very much standardized and it go well within all age group. Recently, we did one 10 months old donor. That's the awareness gone up to that. 10 months old pediatric donor is given heart to the Chennai hospital and the renal donation is given to us. We used as the kind of N-block kidney, both the kidney anastomosis, 62 years old end-stage renal disease. She had dialysis over 10 years time. Now she's doing well. So this case I want to highlight because a donation is not basically on the age. Even 10 months old kid can donate if something is going to be useful for the end-stage organ failure recipient. So this recently happened 2 weeks back in our hospital, and the creatinine all settled down and she's doing well, the recipient. It's a great gift to the life. That's why we say, Urupudanam, Uyirdanam. We promote with so many booklets and even storylines on the organ donation awareness, especially on the young people, especially the college crowd. So this is the anastomosis. We look at that. The renal I compared, only the renal artery will anastomosis to the iliac artery, preferably the external iliac as a end to side anastomosis, and the vein will be connected to the external iliac vein at the end the anastomosis. It's a typical example for a heterotrophic transplantation. Heart is the typical example for orthotropic transplantation. Ortho is where you excise, you should implant it. But kidney, we excise from the lumbar region and connect to the pelvic region. This is a typical example for a heterotrophic anastomosis, where we anastomose the recipient superior vena cava to the recipient inferior vena cava, the donor cava, then the aorta, then the pulmonary artery. And the one is not seen here is the left atrial cuff. So we have to excise the donor heart, the superior vena cava a bit, inferior vena cava, then the ascending aorta above the coronary artery and the pulmonary artery above the pulmonary valve. So this will be anastomosed to the recipient, the pericardial space with the anastomosis posterior, what you see the left atrium. Once you did this anastomosis, the circulation is connected and usually the heart beats off clock. So it will take hardly 45 minutes to 1 hour for doing all this anastomosis. The renal transplant takes hardly 15 minutes. That's why you are concerned about the cold ischemic time while implanting the organ. So this is the way you do the preparation out of the table. You prepare all the additional, because once you take from the deceased donor, you have to consider some of the long length of the pulmonary artery and aorta. Then you dissect in the recipient adjacent table, then connect to this thing. So this is the thing we are highlighting in the initial. The organ, what you take it, it should reach the recipient site in a correct time. And for that, we need a lot of cooperation with our common people as well as the traffic control region, where we have a good green corridor maintenance, where you can transport organ from Trichy, Madurai, even Salem, all these things within 3 hours to get this thing done on time. So that's very important. So the survival of the graft depends on the time of this. So that's why we say time is life, time is organ, and time is muscle. So on time, you should reach the recipient hospital and connect to the perfusion. So this is a very fresh card. It's taken from this thing donor, and now everything established in the recipient side. We have cardiopulmonary bypass. For a cardiac surgeon who operate over 10 years of the field, they can just implant this like any other like operation, like a double wall replacement time. We have to spend for a organ implantation. The heart will be implanted in this time, 1 to 1.5 hour time. So this is the cavity we prepare. So where we start anastomoting first the left atrial cuff to the left atrium of the recipient. Then rest of the thing, what I saw the first picture, we connect the pulmonary artery, then the aorta, then the vena cava, then everything will be connected for circulation. So moving on to the lung is more complex in compared to the heart, where we need to take extra caution in preserving the lung, perfusing the lung, and explanting the lung. This one picture, I just took it from Canada, the Toronto General Hospital, where it's a really world-renowned center for lung transplant. Every month, they do a minimum of 15 double lung transplantation. So this lung so fresh, is need to be connected to a recipient. Most of the recipient will be on ECMO or some kind of artificial lung, novo lung. We need to really transport in a very constrained time to reach the hospital. So this is the way it will be checked in the ex vivo, where we need to assess really the lung is good enough for transplantation, especially if delay over 2 hours time. Then you have to check in vivo, ex vivo for better acceptance for the implantation. So because in the heart, we have a better idea of even sustaining some of the dysfunction in heart by using a post-procedure ECMO machine. But in the lung, it's very difficult to maintain. If the lung, if it's not suitable enough, you can't proceed with implanting it. So that's the pre-procedure. These are the strength initially we need to strengthen. And there is rehabilitation for the heart is very important. The lung also is quite important. The physiotherapist told the post-procedure recovery. So these are the things we are kind of educating for a multi-organ transplant team among the staffs and the administrative officials. So we want to highlight that a teamwork is very, very essential for this kind of program. Teamwork is the ability to work together towards a common vision. So we need to give more life with a better organ, better timing, the ability to direct individual accomplishment towards organizational objectives. See, most of the organizations like to offer an option of transplant program, but the transplant program should run by a teamwork with all the specialized experts in the same vision towards achieving an uncommon results. So that's the thing we are trying to achieve in our center. Now, by this time, we have crossed over 16 heart transplants, over 16 heart transplant, and we did 6 lung transplant. And our renal liver program is going well over 2 decades of time. They crossed to over 15 liver and hundreds of renal. So the success, most of the time we look for a good success stand, but the direction in which we look is the real success. One out of you may have a kind of unacceptable result, but we should persist in working and creating awareness among the common people for coming forward for donating. Because we have a lot of recipient list, but the donor pool we need to extend. Probably we need to do the borderline donor as well as the donor which is going to really give a better thing by using other the transport support machine and the ex vivo perfusion machine. So this is, we just compare the Toronto General Hospital where we are in 2010 plus, and this is our institution where we dreamed in that center. Now we are executing in our center at Coimbatore. So we are happy to see that we are almost par with the global standard of giving the outcome in heart and the lung. Thank you very much. At this juncture, I thank all my senior colleagues and the well-wishers who, with their support in our administration, our medical director, and all other administrative officers for achieving a good result on this area of heart-lung transplant program. Thank you.
Thank you, Dr. Murugesan, sir, for your nice lecture. We will have the questions at the end of all the 4 talks, sir. So now I invite Dr. Sri Ananthanarayabnan for give his lecture on advanced heart failure and timing of the heart transplantation.
Am I audible, sir?
Yes, sir.
Audible.
Good afternoon, everyone. I extend my sincere thanks to the IMA Society for giving us the opportunity to share our work and to set out an educational presentation to everybody. As Dr. Murugesan sir clearly pointed out, ours is a recently formed, but a very well established unit who's performing all varieties of cardiac surgery. And with Pradeep taking lead in heart failure, and we all supporting, we have done some commendable work within a short span of 1.5 years. Pradeep will be talking about it in his presentation. So without wasting much time, I will jump on to my presentation. So our topic today is advanced heart failure and timing of heart transplantation. So etiology of heart failure can be broadly classified into 4 main etiologies. The most important and the most common is the ischemic heart failure. The second most common is the non-ischemic heart failure. And the third is a mixed both ischemic and as well as non-ischemic. Some patients can have parts of both. And the last one is off late, which is becoming more common, is iatrogenic heart failure. Heart failure in itself, it's not a disease like typhoid or diabetes. It's a syndrome. It's a complex disease which is quite costly. It has got a lot of etiologies. At present, approximately 60 million people in the world are affected with heart failure. 83% of heart failure patients are hospitalized due to an acute heart failure episode at least once, and nearly half are admitted at least 3 to 4 times in their lifetime, which is quite high. Every year, there are approximately 1 million hospitalizations due to heart failure. Even in the Western world, a heart failure patient remains in the hospital for at least 5 to 10 days. We all know that. Due to this, heart failure presents a major growing health economic burden, and the proposed burden what it puts on the society is a staggering amount of $108 billion every year, which is quite high. The outlook for such patients is also very poor. Not that they get their heart failure treated and they go back and do wonders. The majority of the times are how homebound. Their lifestyle is quite limited. They don't do much work, and their survival rates are worse than cancers. Majority of the time, what we have in mind is that cancer is the killer. Heart failure we can manage with drugs. Digoxin is there, diuretics are there, but it's not that way. When we count head to head, the number of heart failure patients and the number of deaths due to heart failure is always more than cancer. And unfortunately, the numbers are growing up so fast, which we ourselves are witnessing in our daily practice. We are doing CABGs for people in their 30s and 40s. 40s have become a very common thing. 30s are also becoming very not so infrequent numbers nowadays. So the numbers are going to go up. Furthermore, heart failure has got a tremendous impact on the patients, families, the caregivers, and the overall healthcare system as such, and it is predicted to increase dramatically in the next decades to come. Overall, it has become a major health problem. When we medically approach heart failure, these are the major class of symptomatic class of heart failure, what we know already. They can be said as NIHA classification or the ACC-AHA staging, where A is high risk for developing heart failure, B is asymptomatic, C is symptomatic, wherein NIHA 1 and 2 fit in together, and 4 or stage D is end stage heart failure, where the patient is markedly symptomatic despite maximal medical therapy. As we can see, 0.2 million patients are there or in end-stage heart failure who will require some form of interventional therapy, either in the form of ventricular assist devices or transplant. We can take that 0.2 million is our target population to whom we need to treat or do transplantation, which is a phenomenal number of patients, and there is a clear mismatch from the donor to the recipient population. Once again, this stages of heart failure, this slide tells us how to manage the individual stages. Till stage B, it is all about treating risk factor reduction, treating hypertension, diabetes, and dyslipidemia. As we go up the ladder and we proceed from further stages, stage B to stage C to stage D, the number of drugs increases, and the impact it gives on the society also goes up as the patient progresses in his stages of heart failure. This is a very important slide, as we commonly know that heart failure is generally when the patient is referred to us for symptoms, we communicate in the form of NIHA functional class, whereas a heart failure specialist talks about Intermacs categories. It's completely reverse, wherein profile 7 is reasonably okay, wherein when the patient is in higher or severe disease, they come to profile 1, 2, or 3. Our target is to address patients when they are in profile 4 or just about before they reach profile 3. Unfortunately, the most of the patients who we get are in profile 1 and 2. They have their own disadvantages, which we will come in further slides. So once a patient has got a heart failure, he is generally referred to an advanced heart failure clinic, wherein he will be treated for heart failure. Either he will be assessed whether he has come with an acute heart failure or is he having a chronic heart failure. If he's having an acute heart failure, majority of the times he will need admission, IV decongestive therapy, and further investigations. And everybody plays a role in this, right from their nurses to the whole hospital team. So patients with severe symptoms before diagnosis, they are admitted, they are placed in an inpatient care. Once they are discharged, they have a long-term management, either in a specialized heart failure clinic like ours or a community heart failure clinic. Majority of the times we send patients back to the referral doctors, giving them clear instructions. These are the type of medications what we would like the patient to be on, and we can support the patient on and off, maybe every 3 months or 6 monthly once, just to offload our work, and for the ease of the patient also, so that they can be followed up in their respective nearby places. These are some of the further etiological slides wherein patients can have heart failure mainly due to ischemic heart diseases, and some due to non-ischemic etiologies as well. This is the iatrogenic heart failure syndrome, which is a new category, as we know that there is a storm of coronary interventions. So we do see patients who get complications after interventions, be it percutaneous intervention, be it even heart failure, post cardiac surgery, even post CABG patients do develop heart failure after CABG. Even post TAVI, we have seen complications develop. Though this is quite very, very negligible amount, this is going to come up big time in the future. The next, this slide shows even within heart failure, we can differentiate them into simple, complex, and malignant. Where in simple heart failure, they have only mild heart failure symptoms without major organ dysfunction, and they can be discharged into a stage of compensated heart failure. Complex is acute heart failure with residual major organ dysfunction, discharged, but they are potentially prone to progressive heart failure and recurrent hospitalization. Malignant heart failure syndrome is acute heart failure with persistent major organ dysfunction who have progressive worsening of symptoms despite maximal medical therapy. These are some of the complications of malignant heart failure syndrome. They develop cardiorenal syndrome. They can develop tamponade due to pericardial effusion. They can have mechanical complications, device-related hemolysis. They can have severe hyponatremia due to excessive diuresis, cardiogenic shock, limb ischemia. Name any type of complication. It's quite possible in malignant heart failure syndromes. And so what we need to do is to educate the patient, not only the patient, the family, paramedical personnel education. We should also guide the patient to have regular activities as well. So what comes in preventive aspects is to promote healthy lifestyle and eradicate infections. Every infection puts down a heart failure patient to their grades. They slip down from level 4 or 5 directly to 1 or 2. So at any cost, we should prevent infections in heart failure patients. They are very, they hang on a very delicate balance, and it needs to be managed very effectively. Identify and treat patients at risk, and whenever possible, we should prevent the progression of the diseases from a heart failure to a worsening heart failure or a malignant heart failure syndrome. We should always aim to hold the patient at a simple heart failure category itself. So it's quite a costly, deadly, and a complex clinical syndrome characterized by symptoms both typical like breathlessness and orthopnea, PND, fatigue and ankle swelling, and it is all mostly associated with the raised JVP, displaced apical impulse, gallops and murmur. According to the etiology and the triggering factors with and without signs of congestion caused by structural and or functional or non-cardiac abnormalities. It's broadly classified as either rapid with very fast worsening of symptoms or a chronic heart failure syndrome. Prevalence of advanced heart failure ranges from 6 to 25%. The largest registry of chronic advanced heart failure suggests that approximately 5% of patients with heart failure have end-stage disease refractory to guideline-based medical therapy, which is the maximal medical therapy in whatever they can get. Even with that, they remain symptomatic. So it requires integration of clinical imaging, hemodynamic, functional, and biomarker parameters in the setting of unresponsive optimal medical treatment. They should be categorized as stage D heart failure. So what are the symptoms, or who should be referred to heart failure clinic? Mainly patients who are on class 4 symptoms or and who have episodes of volume overload or peripheral hypoperfusion, who have objective evidence of severe restrictive filling pattern, EF is less than 30, or when the pulmonary capillary wedge pressure is more than 16, or when the right atrial pressure is more than 12, or severely impaired functional capacity, inability to exercise, 6-minute walk test, even less than 300 meters, they could not walk, cardiopulmonary exercise test, peak oxygen, when the VO2 max is less than 12 to 14 ml per kilogram per minute. This is generally regarded as a gold standard for assessing the aerobic capacity of patients in heart failure. More than one heart failure admissions in the past 6 months, the patient should be referred to an advanced heart failure clinic like ours. Above occurring, despite all this we are explaining, despite of maximal medical therapy. So despite advances in medical therapy for chronic heart failure, they carry a dismal prognosis. 75% of patients die within 6 months once they develop that malignant heart failure syndrome, even in spite of maximal medical therapy. In this extremely vulnerable patient, there are light at the end of the tunnel, such as transplantation or mechanical circulatory support. They've greatly improved the outcome for such patients, and they live a very long and satisfactory life. Majority of them are back to their work. They become breadwinners of their family. They even pursue sports. These are beyond the scope of this presentation, so I will limit only to the relevant things to my topic. So intolerance of medical therapy because of hypertension or renal insufficiency is a poor prognostic marker, and it warrants early referral. One important thing is that whenever a patient comes to the heart failure clinic, what determines his outcome is how his end organ functions are. Because anyway, the heart will be taken care by the heart failure guys. But the one thing which is not greatly under control of the heart failure specialist is the patient's end organ function, be it the liver or the kidney. The liver is the most scary thing. So the most important thing, the message what we would spread across to all the referral doctors is that the patient should reach the heart failure clinic with only one organ dysfunction before he develops multiple organ dysfunction. That is the best time for a patient to reach the hospital for him to have the best outcome. Because once he develops multiple organ dysfunction, his recovery phase after a heart failure treatment is also going to be quite prolonged, and it is going to be very complicated as well. So the primary cardiologist of the patient with advanced heart failure, he acts as a gatekeeper and he guides the process of advanced therapies. The gold standard for management of heart failure is always cardiac transplantation, but it definitely comes with the disadvantage of the scarcity of donors. So, and of the selection criteria. So many patients with advanced heart failure with advanced age and multiple comorbidities at present are not eligible for transplantation. To overcome these challenges, mechanical circulatory support like LVAD have become destination therapy for quite a few patients, and they also do quite well. Even with LVAD, it doesn't mean that once we fit a machine, they should be homebound. We have seen patients with LVAD walking around, leading normal lives, going to office, and being in functional class 1 for a long, long time. So dyspnea is often what is an advanced heart failure syndrome. Dyspnea is mostly the characteristic feature. They also have RV failure features such as fatigue, edema, and ascites. They become intolerant to drugs on previously tolerated doses, and they develop hypertension or major organ dysfunction. So advanced heart failure is a discrete clinical syndrome that deserves recognition as a own entity. There is a marked variability, and there is no single feature which we can say that this is the symptom of heart failure. So our aim is to prevent progression of heart failure from B onwards. We should definitely prevent progression of heart failure syndromes to stage D. So as we see, who are the patients who should be referred for heart transplantation or a mechanical circulatory support device management? Age, when at present younger patients are doing better. This is quite a generalized statement. There are a lot of exceptions to this rule. We have done patients even in their 60s and 70s heart transplantation, but that should be a case-by-case scenario. That also depends on the experience of the team. Inexperienced teams, it is better to take younger patients. Functional class 3 and 4 symptoms without reversible etiologies, whom are unresponsive to the guideline-directed medical therapy when their LV dysfunction is very severe. Recurrent heart failure admissions more than 3 in 1 year without any precipitating cause, and heart failure with major organ dysfunction should immediately be referred. What are the indications for VAD? Patients with more than 2 months of severe symptoms, despite optimal medical therapy and device therapy, when they have EF less than 25%, when their VO2 max is less than 12 ml per kilogram per minute, pretty much similar to the heart transplantation indications. Just that we do this when there is a scarcity of organ. We all know that getting a donor is not all that easy, specifically for a heart transplantation. So, to summarize, advanced heart failure syndrome presents a complex set of challenges for many stakeholders, including patients and their families, healthcare personnel, pharmaceutical and device industries, researchers and regulators indeed. Most of the trials of novel medical therapies have largely failed to show benefit in patients with advanced heart failure syndromes. This I am talking about malignant heart failure syndrome, not about chronic heart failure. Yet many effective interventions can still be offered to patients with mechanical circulatory support, as well as heart transplantation. And this is a rapidly changing field and requires skill and expertise to target patients for evaluation of end-stage heart failure. Unfortunately, many patients are referred to advanced heart failure too late. That's the point what we need to drive. And we need to develop simplified pathway to determine which patients are eligible for advanced heart failure therapy, so that patients, the general cardiologist, advanced heart failure clinic can work together in determining the optimal treatment plan. Thank you.
Thank you, Dr. Ananthanarayabnan sir, for giving a nice lecture about taking our heart failure all around. And at the end, we will have the question session. And next, I invite Dr. P. Sivakumar, the consultant cardiac critical care and cardiac anesthesiologist, Department of Cardiothoracic Surgery, PSG IMS, to give a talk on the donor management strategies for better transplantation outcomes. I welcome you, sir. Dr. P. Sivakumar, sir.
Thank you, Rajesh sir, for the nice introduction. I thank the IMA and the chapter of Organs Donation Society of IMA. I thank my chief lead, Dr. Murugesan sir, for organizing this. And so at the outset that already.
Sir, 1 minute, sir. 1 minute, Sivakumar sir.
Yes, sir.
Sivakumar sir has finished his medical training by 2001 from Coimbatore Medical College. He completed his postgraduate in anesthesiology and critical care during 2002 to 2005 in Jipmar, Pondicherry. He did his fellowship in cardiac anesthesia in 2007. He had his special training in heart lung transplant in Leipzig Heart Center, Germany by 2015. He is the consultant lead cardiac critical care ECMO services in PSG Hospitals. Welcome, you, sir.
Thank you, sir. Just a point about our transplant status in India, just to add why the topic is so very important. And as Dr. Ananth presented that the heart failure management, and we do see that we have around 50 lakhs of heart failure patients in India. And when the patient is in advanced heart failure, almost the mortal rate is, we lose them more than 20 to 30% of the total heart failure population every year. And in spite of that, our data is little underreported, and most of our patients don't report it, and it doesn't come into the data, I mean statistics. Apart from this 50 lakhs population, and yearly we add some significant heart failure patients, around 1 to 5 lakhs every year. So this is the depth of our heart failure population and the epidemiological problem what we face in our country. So far what we have seen is around starting from 1994, where we formed our Transplant Act, and so the Heart Transplant started in AIMS, New Delhi in India, and they started very aggressively, and but over 3 decades, right now we are in 2024, and so far we have done only 2,500 heart lung transplants. So, but in the backdrop of so we see that almost every year the country witness around 1.5 lakh deaths due to head trauma. So far we have generated only that 380 cadaveric donors. Yearly the 380. So out of this, it's quite a big gap between the patient, our sick patient, the load of patients what we have, what the society suffers, and how we do, what we offer to them for the heart lung transplant. But the other side, we have so much of head trauma, though the government and other voluntary organizations trying to educate our young India not to have a head trauma and don't be a donor. In spite of that, we witness so many deaths, but a lot of gaps. So we are in the outset that from the public as well as the heart transplant team, centers like us, and we face that we face only few, we get only the few donors, and so our wait list is so long, and we do lose our patients frequently in the wait list, waiting for transplant without getting an organ, and we get the news all the time. Now and then that the family of our patients, they call up, suddenly they collapsed, and all young individual kids, 1 year, 2 year, and very young individuals. So that's a very sad story, and so this is the prevalence what we have. So I'm trying to say that that donor, we know that we have to generate so many donors, and we need to educate the public, and we need to educate the hospitals and our physician, intensivist, and probably there are times that the Tamil Nadu is supposed to be the highest state having a transplant done. Because of the literacy and as well as the government's effort to spread awareness. But still, there are long gap, and recently we see the trend is on the declining trend. Possibly due to that, there is some stigma that our understanding, the public understanding about brain death. So there is always even that movies, they just educate the public that all this brain dead, something like the accusation goes to the hospital, that whenever you get admitted in ICU, probably your organs will be taken out. I think this myth has to be educated, and it has to be removed, and we need to educate the public. And I feel that apart from that, spreading donor donor awareness, we need to educate the public about how brain death happens, what happens after brain death. And this is, I think, all our intensivist collective responsibility to patiently explain all their patients who comes with head trauma. And we need to go for some, even the government has to tell them that what is what. So just from our side, whatever the organ we get, so what happens from our side, the outcome. So what is the outcome? So we get suppose 10 organs in a year. So how it goes about. So one thing, just one concept I just wanted to tell is we call it primary graft dysfunction. And whenever we get a call, we need to travel for 2 or 3 hours and probably the nearby cities. Sometimes we catch a commercial flight to reach other cosmopolitan big cities to fetch the organ. And we know that the heart will, as Murugesan sir said, that it is a cold ischemic, warm ischemic time. And whenever we take the heart out of the body, it just only we have very few limited hours, so that that ischemic damage and with anaerobic metabolism, without any supply of oxygen and other metabolites. And the heart muscle, how long it can survive. So we just ischemia time limits at 4 hours. If it goes more than 4 hours, and the outcome is quite bad, and we all saw that whenever it goes to 4 or 5 hours, we need to after the transplant, we put the recipient on a lot of inotropes, sometimes on mechanical circulatory support to just support the organ because of that stunning and other things. So that the incidence of primary graft dysfunction, and the primary graft dysfunction, it starts from the not only its ischemic time. And a very important factor I just want to stress today is and how we manage our brain dead patients. And it all starts with the management of head injury, and as well as when we certify them as a head injury patient, we have some nearly 24 to 48 hours. And so we all know that physiology of brain death and ICP, how it affects every tissue in the body, something like some electric storm from your head, and it just reaches every tissues. And so I just want to add some points on that aspect of how safe we can handle those patients, which they are very precious, and they have the family have a very big heart to just consent the organs to the suffering recipient population. And it's quite a very few number, and we need to put that in, because we see that up to 30% of all our donor hearts suffer some kind of the primary graft dysfunction. And whenever it is being transplanted into the recipient, once the clamp is off and your coronary perfusion is going, and we wait the heart to beat, and we wait just how best it can eject, and how it generates the systemic pressure. And when you see that, and we do find that up to 1/3 of your organs almost require very significant post-operative. We stack pumps, like adding so many inotropes, and sometimes we go to some mechanical circulatory, IABP and ECMO and other things. And these set of patients will have a very high mortality. Almost half of them will die. So just it's a very big thing. So we lose recipients as well as we waste the precious donor hearts in this scenario. So in that outcome, not only the short-term outcome, and even if they survive, suppose around 50 to 60% patients who survive this primary graft dysfunction due to the cold ischemia and the because of the head injury and all those kind of myocardial injury because of high ICP. And so these things will have a very long-term outcome also. When we just look at the data, and you see that the 5-year survival of a patient who doesn't, recipient who doesn't experience the PGD, and will have a nearly 80% of survival, and even 10-year survival somewhere around 70%. And the data shows that the 5-year survival of patient who suffers, recipient who suffers primary graft dysfunction will have only the 39 or 40% survival. And definitely it is just a waste of resource and so much of effort. And so let us have that some kind of management plan. And as Murugesan sir said, that we are all very, Dr. Pradeep is working with Dr. K.R. Balakrishnan, and we are all just helping me out, just getting a life box where we can just even up to 2 to 4 hours. And when it sometimes we go out of our cities, like sometimes we get an organ where the commercial flight doesn't reach, and though those organs are going some peripheries like in part of South India, even North India, and so we suppose if we have a life box where we can keep the heart safe without much of anoxic injury and with all these acidosis and other injuries. So just we are just coming out with our animal study that we have a life box thanks to Dr. Pradeep and Dr. K.R. Balakrishnan team, and hope that it will come and probably we can reach some remote parts of Andhra or some other Bihar and other wherever we have an organ. Probably we can switch flights, and we cannot afford that jets, which cost somewhere around 8 to 10 lakhs, and most of our patients cannot afford that. Even the transplant surgery itself will cost somewhere around 15 to 25 lakhs. And so this is the setting. And there are some risk factors that predicts primary graft dysfunction. And whenever we see that, whenever you have a recipient age more than 60, but mostly we don't go for a donor who's aged more than 55. And also we try to limit the ischemic time just less than 4 hours. So suppose if it happens more than 4 hours, there is a significant incidence of primary graft dysfunction. And also that somebody who's on our recipient who's on the preoperative MCM, mechanical circulatory support, and these things are going up, incidence is going up. So just the donors, we know that, I mean, most of the heart lung transplant requires cadaveric donors, not like your renal and liver, where we have a lot of live donors, and they are quite picking up, and a lot of centers in India, and they do a fantastic job in liver and renal transplant. But still, as I said in the first slide, and the thoracic organ transplant, heart lung transplant is limited because of the availability of donors. And other point to add is, yes, Murugesan sir, it's a big teamwork. It's not like that because of, so we need a very big team and a lot of specialists, medical specialists, as well as our paramedical staff and good nursing care and other. So we get a good outcome whenever we have a very big team, and the center is a high volume center where they operate somewhere around 5 to 10 cardiac surgery per day. So this is the limiting factors that why that heart lung transplant program is not so great in India. In India, when comparing the Western standards. Hello. Okay. So just when it come to our ICU where we handle that head injury patients, so most of the donors, cadaveric donors, comes from the head injury. So sometimes it's head trauma, and there are few percentage we get patients with intracranial bleed, and so that the ICP goes up, and there is extensive damage to the parenchyma, and no longer the brain is functioning, all the reflexes, all the conscious status, and every higher function, and all this motor activity, reflex activities, everything is down. So from starting from the cerebrum to all the medulla and all the brainstem, so much compression and ischemia and necrosis and trauma, contusion. There's so much of kind of pathologies, and it affects, and no more that person can survive. And thanks to the Act of 1994, then we have a brain death criteria. So whenever it come to that, mostly I'll just concentrate on trauma. So what happens in trauma? So almost a trauma is a highly inflammatory state where we see that so many associated injuries, and you have a parenchymal head injury and activation of coagulation, and there is a lot of endothelial dysfunction, and sometimes they just affect the lungs, and trauma patients presents with ARDS, acute respiratory distress, diffuse alveolar damage, hypoxia. They tend to go for more sepsis. And also because of this high inflammatory things, they might have some hypotension and inflammatory paramediators. And most of them suffer some acute kidney injury, staging from grade 1 to, and even go for some dialysis. So this is the outset. So they tend to have a lot of complications in these patients. So other thing is the exposure to infections. They all having the stay of more than 2 or 3 days, they tend to have ventilator-associated pneumonia and all these catheter and urinary catheter central line associated infections and sepsis. And so there are so many problems. So even if you get a donor, and one side is inflammation, one side is infection, and so most of the head injury patients have high risk for aspiration pneumonia that soils the lung. And there are a lot of times we go and see the lung for the transplant, and mostly if you put a bronchoscope, a lot of secretions, and CT will have a lot of patches. X-ray is bad, all the ratio of oxygen and FiO2. PO to FO ratio will be low. And this is the thing we happen in these kind of patients. Another important thing is the pathophysiology is whenever there is an ICP, so we see that the brain, which is just encased in a very stiff bone, calvarium and other bones. And so whenever there is an edema, like the edema which happens in our other tissues, we have some area to expand, like you have a fracture in the forearm, that forearm swells. And here it is not possible. Whenever the brain swells and it is limited by the space, and there is a high ICP, so immediately that ICP goes up and the edema and collection of fluids and everything builds up. And so that this is the pathology for brain death. But another factor is whenever there is a medullary compression, there is a high chance of very high sympathetic discharge. We call it Catecholamine Storm. And so this kind of very inflammatory and infection, apart from that, we have some kind of sympathetic injury to all our tissues. And there are certain tissues very much sensitive that say sympathetic storm, like cardiac. And whenever you have, we all see that a lot of ECG changes, STT, T-wave changes. If you check your troponin, it will be very high. And sometimes you put a probe, you see a lot of regional wall motion abnormalities. Sometimes you see even EF20 in these kind of patients. So another thing is this directly affects the cardiac function and causes even the sympathetic storm can cause acute lung injury and ARDS also. The another factor is whenever there is a brain death and the hypothalamus and pituitary failure happens, and you know that deficiency of ADH, so they lose a lot of water, that lose so much of water outside. And they are dehydrated, and so the pituitary dysfunction causes all this thyroxine, and all your steroid levels might be low. So this is the general background what we see in these problems we face in all these head injury patients in the regular ICU. Okay. All right. So how we can just manage these factors? What are possibilities that we have that an intensivist have, that how we can just balance these problems, infections? And we all know that nowadays ICUs are well equipped, and we have a lot of specialists, and all our peripheral ICUs are doing very good, and we have very trained personnel over there. And they all have that VAP bundle and infection control and the CLABG bundle and everything. And we do see that fantastic outcomes in terms of infection, general supportive care of all these patients, even in not only in the big cities, even in a small towns. And so that thing is very good. So the one thing which I see that in our experience with all 16 heart transplants we have done so far in PSG Hospital, and our experience says that the Catecholamine Storm is a little underrated. And I would say that nearly half of our transplant donor hearts, nearly half of our donor. Hello? Yeah, am I audible? Hello?
Yes, sir, you are audible, sir.
Yeah, okay, sir. Some disturbance. Okay.
Some other people are also talking.
Yeah,
That is
okay.
the problem.
Okay, sir.
Santosh, please mute all.
So that the little underrated this Catecholamine Storm. I do see that. I just want to convey that something about my fellow colleagues in the ICU. That we usually they look at the brain and just always worry about the outcome, and they just have a lot of they have to spend a lot of time with the family counseling about their brain injury and outcome and neurological outcome. But most of the time, when they decide that patient is going having certified brain death and they're planning for donation, even by the time, and we do see that the most of the time the injury has damaged the heart and lung, and I would probably recommend that so whenever we treat our patients with high ICP, it is not that only we manage the high ICP with surgeries and all our
Santosh, please mute all. Lot of disturbance.
இதெல்லாம் இந்த கல் வாரம் பத்தாது இல்ல அப்புறம் அந்த இவன் இருக்கான் உள்ள கல்லு கிடக்குல்ல.
So I would advocate all our intensivists, and the sympathetic blockade should be part of your the therapy even before we certify some brain death, and whenever even I would say that sometimes the pressure is on the higher side, better to have a when you have a high tachycardia and ICP, along with management of ICP, we all has to give some kind of sympathetic blockade to protect all our organs like lung and heart. The major sympathetic innervation happens in these kind of organs, and probably adding some beta blockers, even the part of your routine protocol. And probably we have to use frequently these drugs to just block the effects of your high ICP on our very sensitive organs, tissues in the body. And also that whenever somebody's brain certified and brain death, there are some reflexive actions will be there, and even when the medulla is no longer active, and there could be some medullary adrenergic surge might be there. And so a kind of sedation and analgesia to prevent the reflexes, even the spinal reflexes and hypertensive reflexes, and all these baroreceptor reflexes. So it is not necessarily that you have to stop your sedation and analgesia if you think that the patient is brain dead. I would advise to continue once that is certified, and you know that, and you can restart the sedation and probably some analgesics to prevent all those reflexive actions which will have some consequence on the heart and lung. And also the sympathetic, something like beta blockers should be added. So some kind of beta blocker sedation analgesia. And another important thing is most of the time due to the ADH deficiency, they'll have polyuria and they have a some hyperosmolarity. And we do see that sometimes the ventricles are so empty and the volume, intravascular volume is so low. So it just leads to, again, renal dysfunction, and so it will affect the organ outcome. So it is better to strike a balance between that kind of good cardiac output as well as adequate intravascular volume, and using small dose of vasopressors. So there are some targets. So how we can set that our patient's targets so that it is good for the patient's outcome. And we just see that heart rate around somewhere around 80 to 110. I would say, if possible, bring the heart rate to less than 100. And since I always think about the our myocardial reserve and other things, I don't want to waste my high energy phosphates in this kind of patients. So better keep the heart very full with some kind of good perfusion to the kidneys and other tissues. And next is we have to keep the pressure somewhere around more than 90, not less than that. And also high pressure is not like something like more than 140, 130 is not recommended. And keep the intravascular luminal well filled and not too overloaded. The too overloaded, some CEP more than 8 or 10 might injure your lungs. There could be some pulmonary edema and as well as renal venous congestion, acute kidney injury, and a lot of fluids. The most important thing is we know that brain and lungs are quite sensitive to your intravascular volume, and your water will seep into these kind of soft tissues. Very okay, right. So the urine output and hematocrit, these are certain things. So other important thing is most of them vasopressin is a very important hormone in this kind of brain dead patients. And there are two things. One is the labile blood pressure is managed by the ADH deficiency. Even normal our adrenergic receptors won't be active unless there is some vasopressin in the blood. So we need to give this hormone. It's very important. And another thing is to have a proper, in the patients with where the blood pressure is so labile and we could not manage, and instead of loading an inotropes, other vasopressors, better to use vasopressin in a physiological dose and thyroxine and corticosteroids, and as I said, that fluid balance. And these are things will help in managing the balance between the cardiac output and as well as the tissue perfusion. So just what we routinely do is from our side, we just check the contractile LV contractions, any valvular leak, and as well as the LVH patients. Somebody is having a hypertension, particularly patients with all this internal hemorrhage, they tend to have hypertension and LVH. These patients don't tolerate the much ischemic time. If you have a less than 4 hours or 3 hours, they do well. When it is borderline, they don't do very well. And also that regional wall motion abnormalities, and we check for all the CAD and other things. So we check the sepsis profile, and so we just want to know whether the infection is, the antibiotics are going and all the infections are controlled, or they are very sensitive. I mean, they're all sensitive to the antibiotics. So another thing is, so when we have a very limited organs, even in spite of assessment, sometimes we do go with even with patients with LV dysfunction and some borderline organs. So that I would say that nearly half of our donors, heart is not fit into the regular criteria, and we need to optimize, and we have to sit with the patients, and we have to communicate with our intensivists and our physicians. And just with a lot of interventions, and particularly in young patients, even when the patient EF is around 30% and they have some valve or leak or something, we have a lot of options to use the organ. And most of them, we see that even the LV-RV is quite not good in these patients. And after transplant, they do very well, particularly from young donors. And the valvular leaks are repaired, and we could do even we could do as a bypass even on the donor heart, and we can use. The outcome is not that differ from that in the borderline hearts in a selected patients. And thank you for the IMA for this opportunity. I thank you all.
I thank Dr. Rajesh Babu sir for giving me this opportunity, and I thank the IMA Tamil Nadu chapter for giving this chance. And at the outset, I thank my beloved HOD Dr. Periasamy sir and my senior colleague Dr. Ananthanarayabnan, who have been very instrumental in developing this program. Since we are running short of time, I plan was done by Dr. P.K. Sen and soon after Dr. Christian Bernard from South Africa. And first successful heart transplant was done in All India Institute in New Delhi, and that particular patient survived for 14 years. And everything has been streamlined once the Transplantation of Human Organ Act came in 1994, and the first amendment was came down in 2011. And now the whole organ sharing platform is managed by Transtan in Tamil Nadu and Noto in India. And all this took big tide after Hitendran effect, which we call as a Hitendran effect. The poor boy who succumbed for a road traffic accident, son of 2 doctors who are willing to donate their son's organ. But in 2008, but by then there was a lot of chaotic situations prevailing in organ sharing. That is when it has been seeded to bring up organ sharing platform in Tamil Nadu, and it all started from 2008-9, and it has been refined, and it has been in practice since 2011. So Transtan has its own credits, which is all seen in the homepage of Transtan itself. So I don't want to go through this in want of time. And I just want to show how organ sharing has been exponentially increasing from 2012. And there was a steep decrease in the pre-COVID and during COVID time, and now it started building up. This is only particular. The previous slide is with respect to all the organs. But this slide is focusing only on the heart. We can see how exponentially it is increasing because of increase in infrastructure and expertise in conducting heart transplantation as well. And this is our last year's Transtan registry, where we can see in Tamil Nadu alone performed 65 heart transplants and 50 lung transplants in the last 1 year. And coming to the long-term, excuse me. Coming to the long-term outcome following heart transplant, first of all, we should know factors which can affect the outcome of heart transplant. First is whenever a heart is combined with any other organ, be it a lung or kidney or liver, the prognosis is not as good as doing heart alone. And when there is a combined multi-organ issues like there is a CKD where creatinine is more than 1.3 and when there is associated liver function with significant amount of fibrosis in liver, and when there is a high pulmonary artery pressures in the lungs, which all has deleterious effect on the outcome of heart transplantations. And when you do a heart transplant post cardiac surgery for post bypass surgery or post double valve or any other congenital heart repairs, definitely the outcome is not as good as doing in a virgin heart. This is because using multiple blood products during the previous surgery, it creates antibodies within the system which can reject your organ. With regard to the etiologies, dilated cardiomyopathy has the best outcome in comparison to hypertrophic cardiomyopathy and restricted cardiomyopathy. And of course, advanced donor age has its own setbacks. And to highlight, this has been published in Journal of Heart and Lung Transplant that patients receiving heart transplant at centers with superior short-term outcomes live longer on long-term follow-up. It means when there is a superior short-term outcome in a center and long-term follow-up of those patients, they are having better outcome. But when in a center who operates very rarely, the long-term outcome is not as good as in a high-volume center. So this is a Journal of Heart and Transplants data on survival in Asian population. And this is based on the UNOS registry. UNOS registry is equivalent to NOTO in United States of America. So the 1 year survival post heart transplant is 90%, and 1 year survived patients, median survival is 14 years, and 5 year survival is approximately 75%, and results vary from center to center, and constant attrition of survival is like 3.4% per year. So this is a JHLT registry from 2017 showing the survival percentage in the pediatric subset. So yeah, as you can see, when you operate on neonates or infants, their outcome is much better, and the outcome drops when you operate to toddler, and between 6 to 10 years, their outcome is much better, and from then on, it is equivalent to any adult community. So this is with regard to the etiology. As you can see, when you do heart transplant for a severely malformed hearts for any congenital heart disease, your outcome is much better. When even in comparing to dilated cardiomyopathy, when you operate a patient for a complex congenital heart disease, your outcome is much better. And based on the Intermacs score, when you, as Dr. Ananthanarayabnan sir, my senior surgeon, he described about how you score based on the clinical picture. Operating on a patient with Intermacs score of 4 has the best outcome than operating on a patient with score of 1. Most often what happens is we are being referred to a patient who is in profile 1. The patient will be in multiple inotropes on ventilator and with all possible mechanical circulatory support, and by then they take the decision of going for heart transplant. Yes, still we can do it, but the result is not as good as when we operate in an early stage. So like I told, when a patient is bridged to heart transplant with an ECMO or a ventricular assist device, the survival rate is poor when comparison to when you operate on a patient who walks into your outpatient department. So this is based on your preclinical picture. As you can see, the red graph indicates the patient being on bridge to transplant with an ECMO or VAD. The results is not as good as patient who has been stable and pre-transplant period. And causes of attrition in survival and quality of life is first is Graft's coronary artery disease. Coronary artery disease in a transplanted heart, which is most often immunogenic, and we call it as a chronic allogenic vasculopathy. And the next is immunosuppressants induced malignancies and immunosuppressions induced renal dysfunction. And last but not least is opportunistic diseases. So what are the other alternatives for heart transplantations? First is ECMO. When you find that heart dysfunction is due to viral myocarditis and you want to bridge this failing heart for some time with the mechanical circulation and then treat him with immunoglobulins or IV steroids, give the heart some time to recover, there is might be a good chance for the heart to recover. In that case, we put the patient on ECMO and we wait for some time. And if the heart recovers, we try to pull out the native heart. And the other option is going for assisted devices using a ventricular pumps, which can be implanted within the heart. And first, initially, FDA approved only for it as a bridge to transplant. You can buy some time implanting all these pumps until you get a suitable heart. But now FDA has approved as a bridge to destination. You can send patients with the home and they can live thereafter with the pump itself. And upcoming field is now total artificial heart and cardiac tissue engineering. And this is a slight overview on ventricular assist device. You can see a ventricular pump is being implanted into the left ventricle through the LV apex, which draws the blood from the left ventricle and it gives out through a graft which goes into the aorta. So this is how it is. Like the pump in the left ventricular apex, a graft to the aorta, and the source of energy for this pump is given through batteries, and this battery is connected through a drive line which enters your body and it is fixed to the pump. I would like to show a small video. This has been published. This has been in circulation for last 1 decade, but I couldn't find a better video to show how this LVAD can be so effective that it can almost give twice the amount of cardiac output what your natural heart can give. So, 1 second. This is very much available in the YouTube. You can see how vigorous this patient does the exercise. So his cardiac output is almost triple. And he lives a comfortable life with a pump within his heart and the drive line coming out of his body. And only thing is he has to carry this handbag throughout his life. So this is an alternative for heart transplant now. And we all pray that after seeing so many youngsters losing their life, despite donating all the organs, we see the grieving family crying and suffering so much post demise. We never want this. Unfortunately, we are surviving out of somebody else's grief. We never wanted this. But if at all it happens, it can save lives. But really, we pray God daily that all this road safety controls should come up and there should be less amount of accidents. And all these mechanical devices should come to replace organ transplantations so that the need for organ goes down and the waiting period goes down and the mortality during the waiting period goes down. And we personally feel this is the future where we are leading. And fortunately, this is very much available in India. We have quite a good amount of experience in implanting these devices. So lung transplantations in last few years, and we have a dedicated ICU for end-stage heart and lung failure, which is equipped with all new age technologies, and we are the leading center outside Chennai who are doing transplant aggressively. And we also relation with the MGM Healthcare, along with my mentor, Dr. K.R. Balakrishnan sir, and Indian Institute of Science, Bangalore. And we get all technical inputs from PSG, reputed institution, PSG Tech. And we are also proud in telling that we are the one of the very few centers in the country who do transplants for infants and toddlers for complex congenital heart diseases. One thing I would request with the IMA organ donation committee is they should come upon bringing guidelines for donation after circulated death and for domino transplantations. And with this, I conclude my talk. Thank you. And I thank all the members for giving me this opportunity. Thank you, sir.
Dr. Pradeep, sir.
Serious and my dear colleague, as you all aware, this is our sixth CME program in organ donation conducted by our team led by Dr. Rajesh Babu sir. Thank you very much for our president, Dr. Abul Hassan sir, for his continuous support. And also, I thank Dr. Senamil Pari sir, our immediate past president, and future president, Dr. Sengutuan sir and Sridhar sir, for their continuous support for this CME program. I thank our secretary, Dr. Karthik Prabhu sir, and all the state office bearers for their continuous encouragement in organ donation CME program. And
So thank you, one and all, sir, for the nice opportunity. And we thank all the participants who have joined in this meeting. And I request all of you to please register your name, the Tamil Nadu Medical Council register number, mobile number, and email ID, so that we will be able to get the credit hours. Thank you, one and all. Thank you so much.